I'd like to call to order this Emergency Services Committee for January the 7th. The first order of business is a declaration of pecuniary interest. It'll remind each member of your responsibility. Undeclared. And next is delegations. Today we have delegations from Debbie Taylor from HealthLinks.
That's no insult to Debbie. Hi folks, I'm Paul Rosebush, President and CEO of South Bruce Grey Health Centre, and I'm here with Debbie Taylor today, our manager of our HealthLinks program for what I call the Southern Corridor, the southern half of Grey and Bruce counties. A few years ago, the government recognized that we weren't providing health care in a very strategic, uniform, and coordinated way, and because of that, lots of patients who we call high users of the healthcare system were being dropped through the gaps in the healthcare system and not getting good care. So we want to have a couple minutes with you today to talk about the HealthLinks system that's evolving, and then what we want to do is talk to you about a couple good success stories that we've had with HealthLinks in our initial first quarter of the program. And then we want to talk about some opportunities we see us, the healthcare network, having working together with EMS in the future to provide an even stronger continuum of care for patients with high needs. I'm just going to be here for a few minutes talking about the program in general, and then I'm going to switch the conversation over to Debbie, who will speak in more detail about some of our success stories. HealthLinks is a program that originated, as I said, because the healthcare system is quite fragmented, and many of the folks that require significant amounts of care and have complex healthcare conditions just weren't getting their care needs met. And the government was debating for years, are we going to develop health hubs? But this particular government went forward with the idea of HealthLinks, which is a program that focuses really on the top 5% of the healthcare users in each geography. And one of the reasons they do that is because of cost. The top 1% of the healthcare users, the high need users, consume about 33% of the healthcare budget in the province. The top 5% of the healthcare users in the province consume about 66% of the healthcare budget. And the top 10% of the high users of the healthcare system consume about 77%. So the government recognized that if we were going to start delivering better care, coordinating care, and lower that cost curve, this was a really good segment of the patient population that really needed better coordinated care. So a few years ago, we embarked across the south to get our partners working together in a coordinated fashion to submit a business case to the LHIN, who submitted our business case to the Ministry for funding. And our program was actually launched officially in September this year after we received startup funding. Our partners are the hospitals, so we've got South Bruce Grey Health Centre and our 4 hospitals. We've got the Hanover Hospital involved, and we've got the family health teams from Kincardine, Brockton, and Hanover involved. We've got CCAC on board as a partner. We've got mental health and addictions as partners, and we've got home and community care as part of our steering group as well. And together we're working hard to identify the high users in our geography and to reach out to them, invite them into our circle of care where we hope to work with them on better care planning so that we can ensure that their needs are met, that they have better health outcomes, and again, that healthcare resources are being used more effectively and more wisely. Up here is a slide which really speaks to what I was just talking about. The print is small, but it just has a circle of care there, and it has all the healthcare partners that are that could possibly be involved. This is a generic slide, and it shows our geography up there as well. Where the province has gone in the last few years, though, is that HealthLinks has become a very robust, vital program in the province. And as of September 2015, last fall, there were 82 HealthLinks in operation across the province with startup funding. And in those 82 health links, over close to 7,500 care plans were developed for these high-need patients. And that's a significant achievement because all of these people are now getting better care, comprehensive care, and having better health outcomes that Debbie will speak about. In total, there's about 20,000 patients who are receiving this and getting better access to primary care. And as you can see, there are so many organizations that are being touched upon to join in the Health Links initiative so that patients can be better served. As a point of interest in Grey and Bruce counties, we've got a North Health Links and a South Health Links. And Debbie and I are here to speak about the South Health Links, but we do work with the North to make sure that we've got some standardization in how we're going about doing our work. But in Grey and Bruce County, when we put together our business cases and we were looking at the complex conditions that are most prevalent in our area, there were some common themes that arose. So COPD, CHF, diabetes, and mental health and addictions are really the high user profiles that we're working with. And Debbie will go into more detail about what the province considers the major criteria to fit into a program of care through Health Links. What I want to say is that we've got great enthusiasm from all of our partners. We're making really good headway with the high users, having identified them and starting to work through them one at a time to get them better care plans through Debbie. And now we're reaching out to work with EMS, and that's why we're here today, to work with Doug and Ray to bring EMS into this fold because they're such a vital part of the healthcare continuum as well. And we think we can have some exciting and better health outcomes the more people we bring into this healthcare journey with us. So I'm here because I'm a co-lead. South Bruce Grey is a co-lead for this initiative. We went after it because we thought this was the right thing to do for our area and for our patients. And on the primary care side, the Brockton and Area Family Health Team are the other co-lead to help drive this initiative. And last fall, we were very fortunate to hire Debbie Taylor, who comes in with a wealth of experience in this type of care planning, most recently from Toronto, and she's helping us to really ramp up our program and make sure that we're going to be able to reach the goals that we're set to reach. So we're in year one. Year one ends at the end of this fiscal year. We're hoping to get year two funding, and then we're going to have to look at a larger sustainability plan beyond that. But this is an exciting initiative that I think Council needs to know about, and I hope that we can work together with the municipalities and the EMS to, again, deliver a better care plan and a better continuum of care for Grey and Bruce patients in the future. So with that, I'll turn the conversation over to Debbie, and she'll share some really exciting news with you on how this program is actually working. Just do that.
Perfect. Okay, and I have the loudest voice, so I don't even know if I need a microphone, and I hate to be very close to them. So I do get to talk about the exciting part about the clients that we actually get to see, and I think what Paul talked about, and it is a health program that's being run out of the LHIN. However, why it's so important, I think, to the municipality and to the county is because what we found in the early adopters of Health Links, so the ones that started over 2 years ago, is it's actually social services, housing, EMS, public health, some health promotion, prevention pieces that actually make the biggest impact on the system in the long term. So I think that the conversation has to happen between the province and the county or the municipal government to actually be able to make the biggest impact. So we are working with Ray and Doug with EMS, but we're also working with Christine and Tanya in housing and social services, and with Linda in public health. So I think that's a pretty critical piece. And it illustrate to you why it's so important, and I'm going to do that first through a case, and I'll share another case a little bit later. And they're actually really sad stories, the clients that I'm meeting or the patients that I'm meeting. So Mike is a client who's 37 years old. He lives at home with his parents. He's extremely unwell. So he's had a massive MI. He only has about 25% of his heart function left. He has diabetes. But what started it all was vomiting, cyclical vomiting, and feeling very nauseous. The medical team has looked at what could be causing all of this, but what's happened along the way is he's got access to a lot of services, but people haven't talked to each other. So he actually had 3 dietitians, one for his cardiac care, one for his diabetes care, and one just from the family health team. That's not a good use of resources at all. He also had 3 nurses, similarly, for diabetic care, for cardiac care, whereas all of them were doing a lot of the same things. But he's been 3 years in the system, and he goes to the ER 12 to 18 times a month. And actually, for the last 2 months, he's been going every day, sometimes twice a day. And a big piece of that is, and so what we did is the HealthLink isn't rocket science, it's bringing everybody together to have the conversation. So around the table we had, you know, his healthcare providers, we had his family, we also brought in mental health and addictions, because anybody who's 37 years old who hasn't tapped into the mental, there has to be some psychosocial component to being stuck at home and being so sick. His whole life revolving around just going into the hospital, basically. And so twice a day to the ER, plus his specialist appointments, plus family physicians appointments, plus with all of these dietitians and nurses, all of those appointments. So we brought everybody to the table, and really, the treatment we were providing him is what was causing him to come to the ER twice a day, because the treatment for the pain was a narcotic, and we were giving it to him via IV, and so he was addicted now to it, and so he had to come more and more to actually get it. And so what we've done with him is, again, by everybody sitting down and us bringing mental health and addictions to the table, and the physician to the table, so the physician isn't working in isolation, we were able to have that conversation with him and his physician, and he came into the hospital for 6 days to get off of the medication, actually, and so he's been out now for just over 2 weeks, and he has not been to the hospital yet. And what we're talking about now, which comes with the social services pieces, is what do you want to do, Mike? Because now that you don't just have to, hopefully, you don't just have to worry about your health care, you need to get back to work. You need to get some kind of interest. Because guess what? All of us, if we were sitting at home all the time thinking about our pain becomes a whole lot worse. So that's the psychosocial part of it. So that's why, you know, we need to look at him moving out. We need to look at him getting employment services. So I'm meeting with the YMCA Employment Services. We're meeting with housing. And so that's the types of patients. But it's not that the solution is all medical. So he's a great example, and he was our top user for the past 2 years of the healthcare system here in South Grey Bruce. So then I'm just going to talk, I have terrible eyes. I'm just going to talk a little bit about what the HealthLink model is and who we're trying to tap into. The goal of it, as Paul said, is just to be more effective in our healthcare system and to bring everybody to the table. We're looking at people with 4 or more chronic conditions, and we're looking at people who have socioeconomic issues such as housing and poverty. And we're looking at populations such as end-of-life, frail seniors, and mental health and addictions, because we found that those are the ones that are the highest risk and the ones that are falling through the cracks. Even if they don't have 4 medical conditions, we are looking at them if they are coming to the ER frequently and or are admitted more than 3 times a year. So again, but 3 admissions a year is a lot for a person, and 5 to 10 ER admissions. Why do we think it's important? Is because we want better care for people. Patients don't know who their providers are. It's a really challenging system, I'll tell you. I've worked in the healthcare system for over 20 years, and when I have family members who are unwell, it's really hard to navigate the system and figure it out, and I'm well aware of it. So for a lot of people, it's really challenging, and they just need help and some hand-holding to be able to navigate and not fall through the cracks. And we want everyone who's involved in the care to know what the patient needs are and what the patient goals are. And so that's where EMS and housing comes in, because you know, you could knock on the door for days and never be able to get a hold of talk to a family physician if you were from the housing group or if you're from the EMS group, even if you're from home and community supports. It's really hard to get talking to people or get talking to people in the hospital. So really, that's all it's supposed to do is break down the barriers. So we do hope to improve health by doing that, by breaking down those barriers and developing relationships with people inside the healthcare system and outside the healthcare system. And the model, again, it's not rocket science. It's about identifying the patients, and we're working with all of our partners to do that. So the hospitals are identifying patients, EMS is identifying patients. I just got a call yesterday from housing who identified a patient who's a potential person for the HealthLink. We then actually meet with them and talk to them about their goals. So it's not about, I just don't want to go to the hospital. It's about maybe I want to get new employment, or maybe I want to be able to go to my grandchild's hockey game. I always use the example of, if somebody told me I had to exercise every day, I might not exercise every day for a physiotherapist, but if I needed to exercise every day to be able to go on a trip to Japan or something, then maybe I would increase my tolerance, right? So it's about finding out what their goals are, and then it's about bringing everybody to the table. As Paul said, there's a north and a south. We are mirroring and doing the same type of stuff. I'm gonna end with another story. Just about Mr. B, and the reason that I'm talking about him is because he actually utilizes EMS services. So he doesn't use Bruce County EMS services. He's actually a gentleman out of Hanover. But Grey County, their EMS services have a number of specialty programs, and I don't know how much you know about those, but specialty programs that look at providing care actually in the home. So not necessarily looking at emergency response, but looking at community paramedicine. And so they do some remote monitoring, so checking people's blood pressure, checking people's weights to try to prevent that they don't get so sick that then they have to go to the ER. So Mr. B is a good example of, he was going to the ER, he'd been to the ER 8 times between January and July, and since then he's only been there twice because he's getting the education and the remote monitoring that he needs from EMS, so that if his levels go up, they go into the home the same day, they provide intervention and treatment, and they can provide antibiotics, they get delegated acts from the physicians, and then they're able to keep him out instead of him going into hospital where he's actually at risk of getting sicker. And it stops it from him getting so bad that then he ends up having to be in the hospital. So again, he's just a gentleman who's in his 70s, who's found it really helpful to have that type of service at point of care, right? So sometimes, and I'm sure some of you know, sometimes you can't get you call to get in to see your primary care physician. It might take 2 days, it might take 2 weeks. And so by that time, you're really, really sick, and you might have to go to, you escalate, and you have to go to the ER. So again, EMS is a great way to be able to do that. So when I talk about some of the opportunities for next steps, we have been working with Ray and Doug and looking at what some of the opportunities are, and they did provide a proposal to us for us to help to potentially support community paramedicine in Bruce County. One of the things that we are trying to do is trying to equalize the access to care that people have. So our HealthLink in the south crosses Grey and Bruce County. There's significant differences in the access that our patients have depending on where they live. And so we'd like to look at how can we equalize that. And so really today, I'm here kind of to plant that seed and to let you know that we are working on some proposals around how might that be possible and how could the HealthLink work with EMS and support EMS in developing some of that community paramedicine, if that's a vision. And I don't know if Doug or Ray want to comment about that.
No, actually, it was just initial conversations. We were looking at what Ray had done. They got funding through initial, same we did with Huron and Perth, where we had the funding to do the community referral training. They did a little bit differently, where they got some paramedics training to go to the home and do some of this. HealthLinks was able to say they might have some funding to do and wanted to know what we could do, and we sort of put out there what we would need to get something going, knowing that it would be very difficult to not difficult to start, but there's a lot of issues still to work through, but we want to know what we could do to get started. So it's kind of initial conversations, and that's why we went here today to just explain what's going on and see where we can go from here. We know this isn't going to be the final conversation by any means, but that's sort of what we had asked for. The discussions on those are still ongoing as well.
And I think the opportunity too, we've raised with the LHIN the importance of EMS. So there is a number of HealthLinks across Southwest, and we've raised with the leadership group at the LHIN around the fact that EMS plays a critical role with these individuals, and so they need to be brought forward into the conversation. Because I know, and I don't know a lot about how all the funding goes related to EMS, but I know that it's from the ministry and from the county, and that it's really hard. If EMS is helping to prevent hospital admissions or prevent ER visits, then they need to be involved in the conversation when we're saving the money on this side of the fence, in essence, with the LHIN. And so the LHIN has asked that EMS Grey County and Bruce County come with us to the next meeting at the Lynn and actually have a conversation about what the CREMS program, which is the Community Referral Program, the EPIC program, which is the one that's being run by Grey County, and the home monitoring program, so that they can increase their familiarity and awareness, so that they can actually integrate that into some of their planning. So again, it's really just our point here today is to raise it here as well as I'm raising it at the other side, because I think that it's important that those two connect, because it is a really critical service and program. Yeah.
Just to go on to that, the way I mentioned how there were the studies, there was a lot of promising stuff there, and there will be data that we looked at, but I really do think the province will be looking towards more programs like this, and that the funding will ultimately even come from them for some of this stuff too. So we didn't really want to be left behind and try and find out what we can start doing right now. So we're not behind the eight ball when they actually did announce anything. And I'm not anticipating it's going to be 2016. I think there's still a lot more going on with the province, but we were at a meeting a month or so ago.
In December 15th, yeah,
And
just.
the federal minister of health came online and did the talk about it, but they were looking at this more provincially, but really paramedics across the nation.